adjuvant always entails the risk of over-treatment and giving drug to people who never needed it. So, in 011, presented in the presidential session just yesterday, Tom gave us maybe a more rational approach to give postoperative therapy.
Yeah, so this is the IMvigor011, as you mentioned, kind of the subsequent from IMvigor010, a negative trial for atezo adjuvantly. I think that's important to keep in mind in resected, muscle-invasive bladder cancer. But the 011 was saying, based on some interesting correlative data, that perhaps we can refine adjuvant therapy based on ctDNA, and we'll get into that. But essentially, this was a design trial which had some updates, but essentially it allowed patients who had muscle-invasive bladder cancer within 24 weeks of a cystectomy and took patients who could have been PT2 or YPT2, which is important, allowing that neoadjuvant component to be given up to T4A or N-positive disease, urothelial cancer, and obviously at baseline not having any radiographic evidence of disease, and then exposing these patients who could have been up to ECOG2 to initially a surveillance period. This is using ctDNA up to 1 year post-cystectomy of every 6 weeks, getting ctDNA testing. And specifically, and again, this differed in China a little bit, but essentially was using the Natera Signatera MRD test. And we can get into the methodology about how much blood and what is actually called positive based on what you find. But essentially, it's using the tissue to inform an assay. So you look at what's altered in the tissue, you're able to coordinate that with the blood assay, and every 6 weeks you get a blood test, every 12 weeks you get imaging.